Hey everybody, Mike Verkest. Welcome to another live edition of the EMS Lighthouse Project podcast. We're going to get our special guest in here in just a minute, but I just wanted to let you all know that we appreciate you jumping on here and spending a little bit of time with us. And I got to tell you, might be a little bit of a longer one today. So let me work on getting our guests in here this morning. So let's start with Dr. Jeff Jarvis.
How doing? It is a wonderful thing to be with you. I am really glad to see you, and I am really glad to see our guest. We have two very special guests. We have talked about them frequently on the show, but their faces have never appeared. Mikey, who do we have?
Working on getting them over there. And they should be coming up. There they are. What's up?
Dr. Crow, Dr. Aaron.
Hello.
Hey.
Dr. Aaron. Dr. Lincoln, your damn name threw me off here. So, guys, we have Dr. Remley Crow. She is the ESO scientist extraordinaire, my number one statistician and methodologist. She is the one that answers all of my questions. Some of them she actually, depending on how many margaritas she's had, might answer truthfully. I'm pretty sure she trolls me with some of her answers just to hear me try to say this wrong and have people laugh at me. And then Dr. Aaron Lincoln. Aaron, wave. Aaron is also a paramedic. And I was going to say I first met her when she was teaching at Temple College, but apparently I first met her as an EMT when she was taking a cardiology class that I was teaching as a resident. She is now a resident at the really long name, basically the UT Dell medical
you can
school.
never get that. You can never get that correct.
I can't. It's Brackenridge. That's the name of the hospital forever and ever and ever. Michael Dell dropped a ton of money, got himself a medical school, and they changed the name.
Yep.
So welcome, y'all.
Thank you.
Well,
Thanks for having us.
Yeah, we're glad you came on. So for those of you that paid attention to 2 podcasts ago on the EMS Lighthouse Project, you know that Dr. Lincoln did a little case study, a little oral board, or I don't know what you guys like to call it, but I reminisce to the days of doing the oral case reviews for the National Registry as a paramedic, and I got to tell you, they're my favorite thing. And we're going to do a little bit of that tonight as we get going with our discussion on hydroxychloroquine. But I will tell you that it just wouldn't be a Lighthouse live if we didn't have a little jackassery to go through, find out how people are doing.
Key, you know, we're to engage in jackassery, but we're missing our chief jackass.
That's true. So for those of you that are paying attention, you might wonder, well, where did Ratu go? Well, he is currently presenting to my fire district board as he's my medical director, and they were running a little bit late, so we'll be fine without him.
I don't know. Jackassery without the lead jackass, not the same thing.
So you guys are all in Texas, and as you pointed out the other day on a post there, Dr. Jarvis, you were talking about you're at the 2nd level of hell for heat. Is that what season you're in or something?
I don't know. I think we might have passed the 2nd level.
I'm sure we did.
Yeah, it's like 106 yesterday. We had a cold front that came through today, and it was only 100.
Yep.
106.
Yeah.
Yeah, it's absolutely disgusting. Yeah, no, it's pretty warm, and this is normally, Mike, where you open up your trap and start telling us how beautiful Oregon is right now. Well, we have the Chief Jackass's chair, and he
was literally just there.
He was, and right as you go live, he runs to the bathroom.
Yep, he's out of there, so that's okay. We'll let that go. I will tell you, in Oregon, now you got to take it for what it is. We're in Oregon, right? So for us, it's been like 100 degrees, but it's a dry, sort of.
It's hot as shit. I don't know what you're talking about.
Yeah. Okay. Thank you.
It's hot.
Hi.
Hello.
Hi.
Oh wait, I'm not supposed to swear on these ones, right? Is that right?
Yeah, well, we try.
Yeah, keep it clean. There,
Was
Dr. Sonny.
that a Maripon that I saw?
Yep, it's a Mirpon Pale Ale.
Very good.
Very standard, old standby. I just got out of another. Sorry for being late. I just got out of another meeting. Been
Well,
zooming
that's
all
what
day.
Mike was covering for you. He was letting us know what you're doing. Carrying out your duties.
Okay.
Yeah, just you know, as our longtime listeners know, I am now Mike's medical director for the first time in our career, even though we've known each other for a very long time and worked together on things. But the board of that fire department had never met me before, except for one member of the board who's also a firefighter in another agency. And so I got to introduce myself to them.
Well, it was interesting because we heard the introduction. We heard.
Yeah,
that,
I was playing that live here
in Michigan.
Go Blue.
OH.
Yeah.
Uh,
geez. Here we go. Hey, before we get going, and believe me, I'd love to spend more time doing this, but we got a lot of stuff to cover. But there's one thing that I want to hit this button right here, send it, that we need to talk about before we get going, and that is that Dr. Crow just won a major award.
Yes, she did.
Oh,
it's a major award.
It is a major award. In fact, it was the best 2020 research project ever in the whole entire world. She just won it.
Well,
in the entire world?
In the whole world.
Of everything?
Of everything. All the things, Ritu. All the things. So, Rimley, tell us about your work. What did you get this award for?
Okay, well, you're going to have to go to EMS World Expo to hear the whole story, but...
Oh, nice plug.
Yes, but we did look at transport patterns for patients with chest pain or suspected acute coronary syndrome. And spoiler alert, during COVID-19, transports went down.
Yes, they did.
Yeah.
Stunning.
And that's it. That's all we get.
That's all you get. You have to come to the
We gotta
International Scientific Symposium at EMS World if you want the rest.
Well, I have my ticket to EMS World, so I'm excited about that.
There's some more important findings.
So here's a great time for me to do a quick plug. And that is, if you're on the fence about doing EMS World or not, since it's virtual, I know that rubs people weird nowadays, but check this out. I got a coupon code for you. If you use FBE 100, that's FlightBridgeED, FBE 100, $100 off.
Wait, can that work for me?
It would work for you, absolutely.
Oh, right.
So people that are watching, if you want to get into this EMS World Expo virtual 2020, FBE 100, they'll get you $100 off, and it's a pretty smoking deal. So you should.
I was only worth 60. Remley 60 is only worth 60.
Yeah, you definitely want the FBE 100 to get that.
Yes, you do.
Yeah.
If I put FBE like 500 in, will I get?
You could try it.
Why not?
All right. Listen.
Hillary's grabbing her chest. She doesn't know why.
Yeah, that's true. I'm just going to leave this a best research thing up here for a while when we get going here. All right. So, Dr. Jarvis, Dr. Lincoln, you guys are going to go through a case. And let's just set up tonight a little bit again. Most people that are watching kind of know what the topic is because we made a big deal out of it. We wanted people to jump in. But we're talking about hydroxychloroquine. A lot of information, a lot of fake news, a lot of real news. It's hard to figure out what's going on. We got the president that's taking it. We got people that are taking it. We got people refusing it to take it. We got people thinking it's the best thing ever. And so the question we wanted to know is, what does the science say? And that's what we do at the EMS Lighthouse Project podcast, is we want to know, we want to shine a little light right on the darkness of some of this crap. So
absolutely.
But
before we do that,
for you, Dr. Jarvis, was that okay?
It was. And I will say this now that Ritu is on, because I want to see his head explode when I tell him this. The whole reason we're having this conversation is because we are spending so much time spinning our wheels chasing a controversy about evidence when there's really pretty good evidence out there. So now that we're starting to tamp things down, we're getting lots of RCTs about or certainly some RCTs about hydroxychloroquine, and we're going to discuss those tonight. It's time for a new therapy. So according to the Pillow King, oleander-based medicines,
Pillow
that's a new thing, and we're looking into it right now. Oleander.
You know, I wish you were joking.
Oleander. Yep.
It's going to start getting crazy.
You're not. That's the problem.
Not joking. Not joking. So everyone has, because I'm sure everybody listens to our podcast.
Absolutely.
I think people may have noticed that we have a new format. And part of the format is we start with an oral board case. So I think we've mentioned this before. So oral boards are it's really the final stepping stone to becoming board certified in emergency medicine. So basically you take your written exam, and then months later, you take a nice little trip to Chicago and you go to practice at ABEM General. So ABEM is the American Board of Emergency Medicine, and they put this on. They rent out a hotel, and they have several floors, and they just put examiners in a hotel room. They scooch the bed out of the way, and everybody's wearing suits, and we're all dressed up and standing awkwardly outside of rooms, just trying desperately not to think about the fact that some stranger in a hotel room holds our fate in their hands. We knock on the door, we walk in, and try desperately not to think that there's a bed and we're in a hotel, and thoughts that come to mind when you're in hotels. And then we sit down and we do what is essentially the it's like, what are you saying? Like, you didn't think it.
It's so weird.
It is weird. So we do essentially what National Registry does, but we'll do it. There's a little more detail. Obviously, in the emergency department, we can order stuff, and we get results of stuff back. We can get X-rays and CTs and ultrasounds, and they'll show us those prompts and give us lab values. And we will do either 1, 2, or 3 patients at a time, a single, a double, or a triple, because part of our specialty is juggling patients. So.
And we don't have to walk in and go,
BSI, scene safe.
BSI, scene safe.
I know.
It is true. It's actually, Ritu, I believe it's BSI, scene safe. So
yeah, we don't have to do that.
It depends. It's COVID. Do you have your PAPR? Do you have your, all of the things?
That's right.
True. And
That's
so
right.
for those people that are watching, like, I want you to participate in this as well. So throw comments in if you're watching on Facebook, Twitter, YouTube, wherever you're watching. Throw comments in there and play along with us as we get this case going.
So, Aaron, are you going to be taking notes?
I do have some paper and a pen, but we'll see.
All right. So it's I don't know about your residency. I don't know about yours, Ritu, but in mine, we actually had very specific formats that they taught us. Draw these things, make these circles, take this information down. And I was thinking maybe Rimley could move the camera around so we could see what you're scribbling, but I think that would probably not work well.
Yeah, let's not do that.
We'll set up for that next time.
Yeah, I'm a bad millennial. You don't want me to do that.
All right, guys, are we ready?
I'm ready.
Perfect. So, Dr. Lincoln, your next patient pops up on the board. It is a 52-year-old male with fever and shortness of breath.
My goodness. All right. And the nurse hasn't run in to come get me yet.
That's correct. There's been no running, no yelling, no screaming.
Okay. So if it's available, if I can see the vital signs, I'll typically look at those before I go in. But if not, then I can certainly go in and just check on my patient.
Your vital signs are available, along with an extensive history of visits for runny nose and sore throat and all sorts of things.
Excellent.
But as a good emergency physician, the first thing to do is go see the damn patient instead of doing your chart biopsy. That's what residents are for. So you do have vital signs, and your heart rate is 130.
Yikes.
Your blood pressure is 142 over 90.
Okay.
Your respiratory rate is 36. Your temperature is 103 Fahrenheit. And
Okay.
your SpO2 on room air is 72%.
Oh, goodness. I'm going to run in there.
Amber says COVID until otherwise proven.
My first question is, why didn't the nurse come get me?
I know.
I was excited.
Right? Why didn't you come get me?
Well, thank you for asking. It turns out that this is one of 18 patients just like it, and you can only scream so often.
Yeah, that's fair. That's fair. All right. So certainly going in, I'm worried about the hypoxia, the tachycardia, the respiratory rate. So I'm going to walk in. And as I walk in, what do I see, hear, and smell?
So you smell your normal emergency department. You see a 52-year-old male. He appears to stated age. He doesn't look cachectic. He's not obese. He is breathing pretty rapidly. He's making good eye contact with you, but he's definitely tachypnic, and he is on room air.
Okay.
52 is not old. I just want to point that out.
What was that?
It is not. And just to be
52 is
clear, to
not
get
old.
all of our nurses off of the hook, they clearly would have treated this patient before, but for the scenario, we're going to make it a little different.
So certainly the 72% SATs concern me. The fact that he's awake and making eye contact is good. I'll introduce myself. Hey there, I'm Dr. Lincoln, and see if he can respond to me as I'm walking in.
Hi, Dr. Lincoln. How are you?
I think I'm a little bit better than you are today, sir. Let's get you some oxygen. So I'm gonna,
that would be good. I've been having some trouble breathing.
all right. So I'm going to get the oxygen put on you. And if I have any help available, if any of the nurses are available to come help, it sounds like I've already got vital signs, but I'll ask the nurse to get an IV started. Hang a small bolus of normal saline and pull labs.
So, Dr. Lincoln, we have you have a brand new nurse there who is not quite sure what flavor of oxygen you would like to administer. Could you clarify for us?
Bubblegum. Bubblegum. I like bubblegum.
Bubblegum oxygen?
Pumpkin spice.
Flavor.
It is going to be fall.
It's almost fall.
Excellent. Well, it's nice to know that I have a nurse that's there to help me. We'll get a nasal cannula going. I am certainly worried in these times about COVID and aerosolizing things and infecting the rest of the department.
You bet. So you apply a nasal cannula, 6 liters, and your oxygen saturation comes up to 92%.
Excellent. How does my patient look with a SAT of 92%?
He looks about the same.
Okay.
He's still maybe 32 now, but he's still pretty tachypnic.
Okay.
And you have an IV of normal saline established, and 500 is going in now.
Perfect. Thank you. So I'll do a few things kind of at the same time. So get a little bit more history from him. So how long has this been going on?
It's been going on about 4 days. The first thing that happened is I started aching all over, particularly in my shoulders, my hips, my legs. I was getting headaches. The highest temperature I had was 102. That was yesterday.
Okay.
And then I had this cough. And now I've just started getting short of breath.
Okay. Have you been exposed to anybody with the COVID virus as far as you know?
Well, as far as I know, no. I don't know of anybody who's had COVID.
Okay. Have you been out and about or working?
Well, I mean, I just go to work.
Well, what do you do for work?
I'm a bartender
Oh.
on 6th Street.
Okay.
It's okay. They all close at 10.
Wait, they what?
They all close at 10.
They all close at 10.
Bars
That's
all close at 10, and the coronavirus doesn't become infectious till 10:02.
Yeah, exactly.
Nothing good happens
Sorry,
after
go ahead.
IKEA closes.
All right. So certainly, COVID virus infection is on my list of concerns. But that's obviously not all that could be wrong with him. So testing wise, I certainly want to get labs. So at least a CBC and a CMP. If I have access to COVID testing, depending on whatever that situation is, I would certainly be interested in testing him for that.
You do. You can
Okay,
get a nasopharyngeal PCR.
Excellent. So that'll be back later.
You can actually do antigen testing also. And you have a variety of PCR tests. You can get them back within about 30, 40 minutes.
Okay, well, perfect. So we will have those results soon then. And then I'll send some
Does
blood
the
work.
flying unicorn bring that to her? Is that what
I
happened?
think it does.
The 30-minute, yeah.
You don't have those in your department yet?
No.
That's too bad. They're really cool. So I'll get a CBC, a CMP, check the electrolytes, check the blood count, see if he's got an infection. Given his vital signs, with the fever, he meets SIRS criteria for sure. So I would, send off some blood cultures. I absolutely want to get a chest X-ray. Let's see. And then there's a whole slew of COVID labs that I can get.
Okay.
But, I know we're not talking about that tonight, but there's sort of varying discussions, and it seems to depend on which hospitalist I'm admitting to, which labs they want.
Sure.
But some of those could be like a ProCal, certainly get a VBG or an ABG with a lactate. Let's see,
Okay.
what else? The D-dimer. Trying to remember all of them. There's some iron studies that I think some people throw in there, like a ferritin, and just kind of look at inflammatory markers with that.
Do you want an extremities exam? Ryan's helping us out.
So, Dr. Lincoln, you have you're in the room, you have sent blood work off. You're going to get a brain biopsy for a COVID test. You're getting a chest X-ray, some blood work. I heard an ABG, a CBC, a CMP, chest X-ray. Is there anything else you would like to do while you're still in the room?
Get the hell out.
I know, right? I think it would not necessarily be a bad thing to listen to lung sounds, but I also don't want to carry that around with me. So if I have, a nice disposable stethoscope or something, that might be nice.
You do? You have one of the little yellow ones. You put it in. It hurts. It takes a core sample of your brain, and you can't hear a damn thing.
Anything. Yeah. Okay.
Right.
There's also some discussion about whether or not it's even important to listen to lung sounds in these patients.
Yep,
So.
I was just reading about that today.
Yeah.
Although I would like to clarify, you don't know this guy has COVID.
True, but I'm going to assume that he does so that I don't get it. I hope.
Okay.
I typically would do a heart and lung exam, plus or minus that, abdominal exam. Kind of look, I didn't really ask for kind of a general impression, but I try to look at, what are his conjunctiva like? Does he have any redness? Does he have a runny nose? That's obvious. Hopefully he's got a mask on. Is he coughing in my presence?
So he has, looks like a little bit of conjunctival irritation. You don't see any overt, great big splotches in the mask. He seems dry. Yep.
Okay. And then I didn't really finish my history with him. I sort of got the story of, 5 days of feeling ill, working as a bartender with worsening symptoms today. But does he have any medical problems? Does he take any medications? Is he allergic to anything?
His only medical problem, he's really pretty healthy. He doesn't really smoke except on days that end with a Y. He has high blood pressure, and he takes amlodipine 10 once a day.
All right.
ACE inhibitors. He should be on ACE inhibitors. Oh, wait, that's a totally different topic.
Yeah.
He very specifically is not on ACE inhibitors. You changer of the subject, you.
What's his oleandrin level?
Oleandrin
Well,
level.
I think I want to propose a change to the way the ABEM does the oral boards. Part of the oral board should include some other guy just injecting comments behind it.
That's what I was wondering. In that gallery,
as a test.
I like it.
Yeah.
It's
Why don't you throw some oxygen on the guy? Yeah, holy. Something like that.
it's certainly more amusing. It's kind of fun.
Indeed.
Okay, so I got a history. I know a little bit more about him. And then in general, I don't see any rashes. He's not reporting any other symptoms like belly pain, nausea, vomiting.
He is not complaining of belly pain. He said, I've had these other weird symptoms, but I think I'm just crazy.
Like what?
It's kind of weird, but my bar normally smells like puke, and it just hadn't smelled all that bad lately.
Ah,
And
Okay.
I mean, people are still throwing up. I don't know what the deal is.
It's a very high-end facility that he works in.
Mm-hmm. Clearly, he's down on 6th Street.
He is on 6th Street. And
we go.
despite this, he doesn't really smell the puke anymore.
Well, you know, maybe that's good. I don't know. I'm not sure. All right. So I think that, you know, a COVID-19 infection is still high on my differential. You know, a superimposed pneumonia would also be something I would be worried about. You know, does he have, you know, sepsis in addition to that? I don't know. We'll kind of see the lactate. We'll see the blood cultures whenever they come back. Given that he came up to 92%, I think you said, was it 92 on the 6 liters?
92 on 6 liters, and he's still tachypnic at about 32.
Yeah. So the other thing I haven't done yet is given him something to bring his fever down. So I think that's probably going to help him as well.
Okay.
And so I'd be curious to see if that helps with his SATs or his respiratory rate. But this guy needs some oxygen support. If that's something that I'm able to,
You are able to do whatever you would like to do.
Well,
There is
another
no
one-
attending stopping you from doing anything.
Well, this is more insurance companies, I think. I know
All of
some
your
places were
techs
talking about.
and your therapists and nurses are just willing to do your bidding.
Excellent. So he needs oxygen support. I know some places were finding ways to get people oxygen at home. I think right now he's probably needing too much oxygen for that. So he's going to need to come in. I think maybe, you know, some high flow nasal cannula if we're set up to keep it, you know, COVID protected.
I'm sorry. I probably should have mentioned this. You are in room 342, Hut 1, and it is a negative pressure room.
Hut 1. Okay. Excellent. So then maybe try some high flow nasal cannula, see if that helps his work.
What would you like that set at? You have two
Oh.
choices, 40 or 60.
Start with 40 and see how that goes.
Okay. Within, say, 5 minutes on 40 of high flow nasal cannula, his SATs go up to 99. He's still a bit tachypnic, but it dropped down into the mid to upper 20s. And he is able to talk to you much better sentences now. So complete sentences, as a matter of fact.
Oh, well, that's great. Sounds like he's coming in on high flow oxygen.
Yep, much more comfortable. So your labs come back. You get a chest X-ray that shows bilateral infiltrates scattered throughout both bases.
Mm-hmm.
Ground glass opacities, possibly.
Not so much on the chest X-ray.
Okay.
Now
You're not our radiologist.
Does it
Our
say
radiologists are literally reading every chest X-ray right now as ground glass opacities.
cannot exclude, and I'm like, it was a rib film. So, yeah, that's your chest X-ray. You have a CBC.
Okay.
Your white count is 14.
Okay.
Don't really see a high granulocyte count. Lymphs do look a little bit low. Hemoglobin's 15. Your platelets are 312.
Okay.
Your CMP comes back. Your sodium is 128. Potassium 3.6. Chloride 104. Bicarb 20. Your BUN is 45 and creatinine is 1.1. Glucose is 108. And your anion gap, hopefully I got this right, is 4.
Yeah.
You, I believe, asked for a lactate. It was 1.8.
Okay.
Your D-dimer is 3.5. Units over units, whatever the hell that comes in. It's high.
3.5.
There's a little H
What's
next
the
to it.
normal range in your lab?
Less than 0.9.
Okay.
So high.
Yeah.
And I have note nanogram per something liter.
Picocuries per molecule.
High.
Yeah.
Your procalcitonin is 0.3. Your normal is less than 0.5.
Okay.
Your ferritin level, because you clearly wanted a ferritin level, is also a little bit on the high side. And your LDH is high as well.
Okay.
I think you asked
You get a
for
C-reactive protein yet?
C-reactive protein and SED rate are both elevated.
Okay.
She waited the full hour on that SED rate.
Correct. No, you have to add that on just because the nurse didn't come get you. You're like, oh, there is one other thing I want. Your ABG has a pH of 7.45. This was the initial drawn on room air as they came in. Your PaO2, again on room air, was 50. CO2 is 24, and your bicarb was 22.
It's expected.
Okay. And I believe that's everything you asked. Oh, and your COVID test is still pending.
Of course.
Oh, come on.
Of course.
Well, who cares what the COVID test is?
It's probably negative because, you know, there's so many false negatives.
There's a lot of discussion in the comments about that, actually.
Yeah. Yep. So clearly this guy's going to be admitted. It's probably negative. You know, I think one of the things we've treated his fever. I've given him some fluids. You don't need too much fluid, is my understanding, to these patients. His labs aren't terrible. Sodium of 128 is a little bit on the low side, but I think that's probably okay for now. And it might get better with some fluids. His ABG is as I would expect it to be, given his presentation with the low oxygen and the tachypnea. What else did I write down?
I think you wrote.
Was there a sugar?
There was 108.
Oh, 108.
So he's not a diabetic. He's not obese. I know those are two things that are concerning for prognosis. And then the only other thing,
Aaron, you also had a positive D-dimer.
Yeah. That's an interesting discussion we could have. Knowing that goes up significantly when the patient has COVID. I know some of my attendings are saying, we're not even checking a D-dimer, and then the medicine docs end up ordering it.
But you checked it. Now you got it.
Now I got it.
You rolled the D-dimer dice.
Yeah.
Played the D-dimer lottery is what we refer to it as.
I see. So I can certainly scan him for a PE. I think he's probably got the COVID as his cause of his elevation.
Aaron, what do you think the odds are when you make that phone call to admit this patient and they see an elevated D-dimer that you're going to be able to get them admitted without a CT scan?
It depends right now with the COVID. If I had the positive COVID test, some of my attendings are admitting them without it, especially if they're low risk otherwise. And they have obvious signs on their chest x-ray. They're actually using the D-dimer to sort of help say, like, yes, it's bad enough that we should admit them or not.
Must be nice to be in an academic center. In my community hospital, there's no way in hell I can admit a hip fracture, and the hospital is just like, could that be a PE?
Yeah, that's the reason that I hedged, is because we've been doing the D-dimer as part of the workup, but if they're known COVID and we don't have a high suspicion for that, we're not necessarily scanning them.
So here's the kind of the fun thing. What is one of the complications of COVID?
Clotting.
Yeah.
Yeah.
So you get a CT scan, and what do you know? There's no PE, segmental or subsegmental. There's no strain you see. And Ritu, what are we seeing?
Ground glass opacities.
There you go. You didn't think we were going to get out of this without that, did you? I was just going to give it to the CT scan. All right. So what do you want to do for this gentleman?
Admit him.
Okay.
To the hospital for, supportive care.
What kind of medications are you going to give him?
That is a great question. I'm not going to give him any hydroxychloroquine.
Okay.
I might think about giving him some dexamethasone.
Okay.
We have definitely added that one in. And then I hear there's, another one that might be useful. We have not added that to our regimen that we're giving.
Remdesivir?
Yeah, remdesivir. I was like, it's not ritonavir. Remdesivir.
We'll talk about that one.
Yeah. So we'll talk about it.
Talk about that.
It's not typically something that at least most places that I'm familiar with are doing downstairs. It seems to be done upstairs in some places. We'll talk about the wisdom of doing that. Let's see. What else did I want to hit on? Okay, so how about it could be kind of look like bilateral pneumonia. I mean, community acquired. Normally, I'd throw some Zithromax at that. Maybe a little Rocephin.
Yeah.
Oh, by the way, your COVID test comes back. It's positive.
I haven't read anything that says one way or the other. I think about half the people I work with are going to start antibiotics. I think this guy probably would get antibiotics, at least in the emergency department, because he kind of meets the sepsis type criteria. And his white cells are actually up instead of down, which I've also seen. So probably treat him for community acquired pneumonia on top of the COVID.
Okay. Now, you gave those antibiotics, and there was a nurse that came in. She's wearing a white coat, hasn't seen a patient in 30 years, and she is talking to you about this mortal sin that you just committed because you gave these antibiotics without getting
Blood culture.
I did say blood cultures.
Did you? I'm sorry, I didn't hear it. Good. Thank God for that.
I didn't hear it.
Okay.
I said sepsis workup.
Oh, sepsis
Blood
workup
cultures. I said blood
covers
cultures.
everything.
You know,
She was early
That'll
on
go
that.
real well on your oral board, Aaron.
Do what?
That'll go very well on your oral board. I said sepsis workup. That means everything that could possibly be done for sepsis.
Whatever.
you got you also got an elevated serum rhubarb level.
Rhubarb level? Okay.
Rhubarb level.
That's
All
cool.
right.
Is that like,
So-
is that like fluid?
Absolutely.
Okay.
It's a Rick Picardism.
Deidre says that I ordered cultures.
Okay, very good.
All right.
Very good. All right, so that's all I have. I would like to go over what your so two questions for you.
Sure.
Ritu,
Yes.
say 2 years ago, this patient rolls into your department. 52, he's tachycardic, he's febrile, he's tachypnic, he's hypoxic. He's got febrile cough, and he's short of breath. What are the odds that you will not have ordered antibiotics by the time you walk out of that room?
Oh, 0.
Yeah. So we just, hands down, this is clearly sepsis. It's clearly from community-acquired pneumonia. We're just going to throw antibiotics at it, which is probably the right thing to do. And it is an interesting contrast because now we're thinking COVID. I still think probably the right thing to do is put some antibiotics in there early. Now, there clearly are some things that are, and well, bottom line, he has pneumonia. There's no doubt about that. It's just the etiology of the pneumonia.
Yeah, we're still treating all, I mean, I would say, at least in my practice, we're still treating, if somebody comes in with an infectious profile and there's an infiltrate on the x-ray, we're treating it like a community-acquired pneumonia.
Yep.
We're
Yeah,
just
I
adding
think we have to.
things to the regimen. That's all.
I agree. So, Aaron, let's run through a couple of things that I wanted to know.
Sure.
What was your differential on?
So my differential included everything from asthma, a PE, pneumonia, either the COVID pneumonia versus a bacterial pneumonia. The fact that he's febrile makes me think it would be less likely to be something like pneumothorax, but that certainly could be on the differential. That would be weird, but it's there. I didn't ask him about any trauma, but certainly, some sort of traumatic injury could have been there. That also seemed very not likely. Trying to think, those are the big ones. He could have had. I didn't ask about cardiac history. I know COVID has, the potential to cause myocarditis. So we could have had sort of a cardiac related dyspnea as well.
So good. Anything you would add to that, Ritu?
I don't really think so. I mean, she hit the high points, I thought. There's
Yep,
nothing-
I agree. So what about meningitis? I mean, he'd fever and he'd been having headaches. Clearly, that's got to be meningitis, right?
Sure. That meningitis that causes hypoxia.
Absolutely.
That's the one.
Mhm.
The reason I bring that up is we do get that a lot. People will put fever and headache as the chief complaint, and you walk in and they're clearly that's not it. Any fever, you're going to get headaches. So we have a tendency to jump all over meningitis. It's usually not meningitis, or at least bacterial. Let's do a little what if.
Uh-oh.
Let's say you had, when you were searching for rashes, you didn't find a rash, but you did find a great big red, swollen, painful lower extremity.
I would be much more worried about like a DVT or a PE
Okay.
as the cause or associated with that for sure. It could be cellulitis as a cause, although cellulitis on top of COVID, I mean, I guess I've seen it, but those patients seem to have cellulitis chronically. So,
Yeah. And Ritu's point is pretty good. I don't know that I've seen a whole lot of cellulitic induced hypoxias before.
yeah. Yep.
Okay.
You just haven't been around long enough.
It's very possible. I am a young man after all. I mean, I'm not like Ritu.
You're quite a
The
bit
elder-
younger than me for
The
another
elder statesman here.
month. 2 months.
All right. So I think we have probably milked that case for all it's worth. Dr. Lincoln, anything else you want to add about the case?
I don't think so. I
All right.
think
Ritu?
that's it.
No, I mean, this is a case that we're seeing every day, multiple times a day, and kind of everywhere.
Yeah.
Yeah, and I'd say it's the same people we're encountering out in the field, right? Perhaps they're waiting a little too long to go in and seek medical care. I think we're all seeing that. People are coming in a little bit sicker than we might have seen in previous days. But yeah, this is the same people we're going to be bringing in on the ambulance. And I think the same fundamental things apply, right? Checking their oxygen, making sure their vitals are good, getting their stats up if you can, and just getting them in there and letting them know kind of what they're going to be in for over the next several hours, right? When they make it to the ED. This is going to be busy.
So one of these things, one of the big clinical questions. So there are two places to go with this. One, Ritu, going back 2 years ago, what is the likelihood you would not have intubated this patient early? Assuming you could appropriately pre-oxygenate him. He's breathing 36 times a minute.
Oh, I mean, 2 months ago or 6 months ago or
We'll say 2 years ago.
2 years. I mean, but it's changed so much, and even like in the last couple of years. I mean, a lot of the sepsis stuff, we weren't our intensivists did not want to be overly aggressive, right? Like some of the other reads of the literature on sepsis about early intubation and sort of managing acid-base status that way a little bit rapidly. So, I mean, I think we would have tried a couple of things. I would have walked in that room and said, let's get our intubation shit ready just in case.
So I think you would probably say that you're definitely going to be much more hesitant now to intubate him.
Yes.
And
although
let's
6
go
months
back
ago, we would have
to
been not as hesitant, right?
well, I was about to say, so let's say now versus 3 months ago in March, I think we probably would have tried him on a little nasal cannula and said, well, he's requiring too much, therefore for our safety, and he's going to fail anyway, so let's just tube him. We might have been inclined to intubate him rapidly.
Yeah,
we're changing that now.
We were, if you got above 6 liters for oxygen, you intubated him.
Yeah.
That was our cutoff. So that was in March and April.
Right.
And
So many things have changed.
don't give them a steroid in March and April.
This is true. This is
But
true.
we'll talk about that also.
Yeah, here's a little sneak peek. Don't give them hydroxychloroquine as a
Which we did. I mean, I admitted my first
prophylactically.
first COVID patient that I admitted, got put on hydroxychloroquine.
So that was a good segue. That's where I was going with this. We talked about airway management. We'll just leave it at that. Let's talk drugs. So we have clearly heard hydroxychloroquine hydroxychloroquine, zithromycin, remdesivir, and dexamethasone. We'll leave the oleander alone. And how about get to the literature now, and let's take a look at some papers on, you want to do hydroxychloroquine first or remdesivir and dex? What do you think, Mike?
We can do whatever you want to do. You choose. I just got to know how to set up the slides.
Well, let's do a little mixture here.
Okay.
Let's talk some hydroxychloroquine first, and I'm going to talk about a positive study that I think people have probably heard an awful lot about, and then an almost identical paper with a different outcome. And then maybe Dr. Crow can discuss some methodological issues with these types of trials. And then we can take a little bit of a break from hydroxychloroquine, deal with some antivirals and some steroids, and then talk RCTs from hydroxychloroquine. And at the risk of really bogging down in this, I think I just want to take a high-level look at these papers. Just what are they, what do they do, and what do they find? Sound okay?
Sounds good.
Sounds good.
All right.
I reviewed the Deep Seaman paper too. Was that
Say again?
one? Never mind.
I am a little bit off, so there is some AV desynchrony here, but it looks like you got up the first paper. That is what's live. So this paper is treatment with hydroxychloroquine, azithromycin, and combination in patients hospitalized with COVID-19. This is the Arshad paper, otherwise known as the Henry Ford paper. I have seen, this seems to be a very popular paper among people who are looking for reasons to use hydroxychloroquine. So just overall, this was methodologically, it was a multi-center observational study. So this was done in the Henry Ford system. And I'll go through just the PICO here, the problem, intervention, control, and outcome, or the population. So they looked at consecutive hospitalized adults that had COVID as tested on a PCR test from March 10th through May 2nd. Now, there wasn't really an intervention or control group. There was just more of an exposure based on the nature of this study. So the exposure was, there were basically 4 groups. Group number 1 got only hydroxychloroquine. Group number 2 got only azithromycin. Group number 3 got both. And group number 4 got none. So that would essentially be your control. And their outcome was in-hospital mortality. So props to looking at a good outcome. I mean, we care about that one. So what did they find? Mikey, we should have some nice pictures about what they found. All right, so here is one of these. And as you take a look at this, this is table 1, which typically describes the characteristics of a patient. And it's clipped. The main thing I want you to look at is down at the bottom. And take a look at the proportion of each group that was given steroids. So the group that had overall 62% of the patient population got steroids. In the group that got neither Zithromax or hydroxychloroquine, 36% had steroids. Hydroxy alone, 79%. Zithromycin alone, 39%. And hydroxy and zithromycin, 74%. And that is clearly, you don't need the p-value to tell that that is a statistically significant and clinically significant difference. Let's go to the next slide, and we're going to look at what the overall survival rates were. So this is a Kaplan-Meier survival curve. And basically what you're looking at on the y-axis is survival. So up at the top is all survivors. And then down at the bottom is, I think in this chart, it's 50% survivors. And then your x-axis across the bottom is days after admission. So at the time of admission, everybody's alive. Otherwise, they wouldn't have been admitted. This was a pretty sick group of patients overall, like 23% mortality. So you're going to see a fair amount of death. And by 28 days, which is where your outcome was, you can see where the different mortality rates were. The green here, so the top bar was the patients who had hydroxychloroquine alone. The black was those who had hydroxychloroquine and zithromycin. Blue is zithromycin alone, and then red was the control. And you can see that the group, there are basically two lines there. The group that got hydroxy and the group that didn't. And they separate off pretty quickly. So that would seem to suggest that there is a benefit to hydroxychloroquine. And then the next Kaplan-Meier curve basically does exactly that and just compresses this down into two groups. Those who got hydroxy in the green, the upper part of the curve, and those who did not, and that's the red. So the bottom line take on this is, let me see if I can, I actually wanted to read you the abstract and I can't find it, but they were pretty ballsy in their conclusions from this. The
older doctors that the congressman was talking about when.
And what they said is that it wasn't quite this strong, but they really made the case that hydroxychloroquine is associated with improved survival and really probably should be used. So, Dr. Crow, what, from a methodology standpoint, what would stop you from recommending hydroxy, assuming you don't know anything about the other literature, and what was known when this paper first came out? I believe it came out before any RCTs, but there was certainly conflicting observational data. So what would you think about this from a methodology standpoint?
Well, first of all, one study is just one study, so we'd have to look at that, you know, in the face of other research also going on. Being a retrospective observational study, I'd pay very close attention to that table 1, and that use of steroids is something I would for sure pay attention to. So we try to think about what are the confounding variables, what else could be explaining the results we're seeing. And yeah, I mean, I think we can turn it over to a friend of mine who can give you probably 5 years worth of epidemiology in about a minute, if you like.
I think that might be kind of cool.
Maybe we should do that. So let's get this going.
We got a special guest.
Yeah, we got a special guest. Many of you will know Dr. Tony Fauci, and he's going to come on here and give us a little bit of information about this very study when he was asked about it. So let's see how this goes.
That was published was a non-controlled retrospective cohort study that was confounded by a number of issues, including the fact that many of the people who were receiving hydroxychloroquine were also receiving corticosteroids, which we know from another study gives a clear benefit in reducing deaths with advanced disease. So that study is a flawed study, and I think anyone who examines it carefully is that it is not a randomized placebo-controlled trial. The statement, it doesn't matter. You can peer review something that's a bad study, but the fact is it is not a randomized placebo-controlled trial. The point that I think is important, because we all want to keep an open mind, any and all of the randomized placebo-controlled trials, which is the gold standard of determining if something is effective, none of them had shown any efficacy for hydroxychloroquine. Having said that, I will state, when I do see a randomized placebo-controlled trial that looks at any aspect of hydroxychloroquine, either early study, middle study, or late, if that randomized placebo-controlled trial shows efficacy, I would be the first one to admit it and to promote it. But I have not seen yet a randomized placebo-controlled trial that's done that. And in fact, every randomized placebo-controlled trial that has looked at it has shown no efficacy. So I just have to go with the data. I don't have any horse in the game one way or the other. I just look at the data.
It won't